aspects of the neuronavigation and what are the principles and different techniques available and different indications and what are the future implications and latest developments in neuronavigation. First of all, we are going to define the neuronavigation and its operating principles. Then we are going to have a workflow or different steps of neuronavigation and then different indications and contraindications or different complications which can occur during the neuronal navigation. And also we are going to discuss the different latest developments such as the AR and VR augmented technologies which are going further in the development of neuronavigation. First of all, neuronavigation in the neurosurgery, as we know, we have to operate some lesions which are very deep in the brain, which are very small lesions or very in the deep areas of the brain, such as near the base of the skull or near the basal ganglia or near the brainstem. So these lesions cannot be accessed properly through naked eye or through conventional surgical procedures. So we have to localize these lesions during the surgery. So neuronavigation acts like as a GPS for the brain, as we know that the different satellite based GPS are available for our navigation when we travel to somewhere in our car. Then we can then map is available such as Google Maps, which guide us through the different routes and the shortest routes available. So neuronavigation is just like the GPS system of the brain. When we are going to operate or approach a surgical procedure, or we are going to uh, access small or deep situated lesion in the brain, then neuronavigation acts as a GPS. It guides the surgeon through which approach and how much deep the lesion is situated. So the basic principle is that it maps the brain. Neuronavigation maps the brain through different images. It receives different images such as the images of the MRI or the CT scan. Then it forms a 3D map of the brain through which it can guide the surgeon about the anatomy of the brain and different allocant areas of the brain. Types of neuronavigation. Basically, we can classify the neuronavigation on the basis of the three types, such as some are stereotactic frame based, which are the rigid frames that are placed on the skull or head of the patient, which is under anesthesia, and then these rigid frames guide the surgeon. This is called the stereotactic frame based neuronavigation. Then we have the frameless technology, such as which can be on the basis of the optical technology, which uses the different infrared cameras through which it can locate the anatomy of the brain, and also through the electromagnetic waves. The other is the electromagnetic wave. These are the two types of the frameless tactic navigation. During intraoperative imaging, these are images can be obtained, or the map can be formed before the surgery and during the surgery. Some other some other modalities can also be used, such as the intraoperative MRI or ultrasound imaging during intraoperative can also be used. These are the examples, some of the examples of the frame-based stereotaxy, or a rigid frame fixed to the skull defines a precise 3D coordinate system. It is more precise than the frameless neuronavigation, but the drawback is that it is a rigid and cannot be flexible during the intraoperative surgical procedure. Uh, it was used before the development of frameless neuronavigation, but sometimes nowadays it is also used during deep brain stimulation in some procedures, such as the biopsy of deep-seated lesions and deep brain stimulation and stereotactic and encephalography. So the core principle is that co-registration of patient space with the image space. So basically, before forming a setup, the neuronavigation system receives some images. So these are the preoperative images, such as the CT scan or MRI. These are images. The neuronavigation system receives the images, and the other is that the head of the patient or that is lying on the operating table. So we have to coordinate these images. So one space is the patient space that is on the operating table, and the other space is the pre-operative images which are available of the lesion of the patient. So the neuronavigation system coordinate these two images and forms a map during the operation, so that surgeon can that can guide the surgeon to locate the lesion. Different that is called the registration of the patient. During registration, different techniques can be used, such as some fiducials, or these are the surface landmarks that are placed on the skull of the patient or scalp of the patient, which can guide about the anatomical locations of the patient. And then a track or probe, which may be a surgical instrument, can be used and placed over the skull or scalp of the patient, that can localize different areas. So different software systems are available. Neuronavigation, basically three main neuronavigation systems are available, such as Medtronic's Brain Lab, Striker system is also available, and Radionics is another neuronavigation system which is available. Some open source are available, such as 3D slicers and research toolkits, but these are used for only research purposes. Uh, then diffusion tensor imaging tractography. What is diffusion tensor imaging tractography? Is that it can localize the different white matter tracts of the brain, and functional MRI of the brain can also be used during the operation and before the operation. Then we have the navigation system components. So we have the neuronavigation system, which and with the monitor, and there is a localizer, and there are also some gadgets such as the patient reference, which may be on the basis of the optical technology base or the electromagnetic wave base. And then we have some specialized instruments such as the probes, which are placed on the head of the patient. And then we also have to do the preoperative images that need to be fed into the operating system. Then specific softwares which are within the system. So these are the basic components. So, for the workflow of or the different step-by-step guidance to the neuronavigation is that we can divide it into different steps, such as the pre-op imaging, such as we obtain the pre-op MRI or CT of the patient, that is that is fed into the neuronavigation system, and then there is the registration of the patient, which is the key step in the neuronavigation. If we make any mistake during the registration of the patient, then it can lead to inaccuracy. So the registration is basically, it matches the patient anatomy which is on the operating table, and it matches the anatomy of the patient with the pre-operative images. That is called the registration. Then localization. After coordinating the patient anatomy and pre-operative images, we have to localize the lesion. That localized lesion can be localized, and then we have to again second time verify the lesion. Then we can proceed for the operation or the surgery. And intraoperative imaging, such as the functional MRI or ultrasound during the operation, can also be used. And then there is a image fusion, that is merger of the pre-op images and intra-op images. And then we can visualize or localize the exact lesion and then excise. So obtaining preoperative images. So there are different methods of obtaining preoperative images. CT can be used in some cases, or MRI is mostly used in the most of the cases. So different fiducial markers can also be placed before imaging. So different markers are placed on the scalp of the patient or head of the patient, that may be the anatomical locations, and then the preoperative image is done, and that patient is asked not to remove these fiducial markers. So during the operation, these fiducial markers are still in the place, and these are compared with the preoperative images. The system can automatically generate the synchronized images. There is the patient registration. So there are different methods of the patient registration. So we have to localize the anatomy on the patient operating table and compare it with the preoperative images, or coordinate these images with each other. So there are different methods, such as the anatomical pair points, which such as the tip of the nose, bridge of the nose, or different anatomical markers such as the superior border of the ear or inferior border of the ear can also be used. Coronal sutures, the different anatomical markers are used. Another method of patient registration is that laser surface scan. Different lasers can also be used for scanning the patient anatomy. Then it can be coordinated with the preoperative images. And then are skin marker fiducial, which are placed before the preoperative imaging, and then on the operating table these can be coordinated with preoperative images. Then there is the tracking, surface tracing, which is mostly used nowadays. So there is a probe that was shown in the some images in the equipment, that there are some probes or surgical equipments that can be placed on the patient head, and that the system or the infrared cameras or the electromagnetic waves that can be detected by the system. So when we place on the different anatomical points, then it can detect the different anatomical points, and then it can synchronize the preoperative images with anatomical location of the patient. Then localization of lesion and anatomical structure. As we can see that there is a infrared camera, and that there is a probe on the patient, and it registration of the patient, and then navigating the lesion uh, of the patient. We can place different anatomy. So the camera continuously links the probe to the patient reference, and lets the surgeon reach deep lesion and project adjacent structures. So when the registration is done, the lesions can be localized. The system generates a 3D images. It can provide the coronal views, sagittal views, and axial views as well. Then is the visualization of the patient. So the after registration, the system generate these images, such as the axial view can also be seen, sagittal and coronal views of the patient can be seen, and there can be different when we place the probe on the patient or surgical instrument which needs to be inserted for the guidance, then that can be seen as the green arrow or the yellow or blue arrow in different neuronavigation systems. Then intraoperative imaging and fusion. So sometimes we have obtained the preoperative images and registration of the patient is also done, but sometimes during the operation the brain shift can occur. What is brain shift? That during during intraoperation, there may be changes in the anatomy of the brain, such as if we drain the CSF, then the brain anatomy can be drained, or due to gravitational effect of the due to gravity effect, the any lobe of the brain can be placed down. CSF is drained, then brain retracts, and also there may be severe cerebral edema during operation that can lead to alteration in the anatomy of the brain, or that maybe lead to further inaccuracy or precision. For this, the intraoperative imaging is advised, such as the functional MRI or intraoperative MRI can be used, which can help guide further for the localization of the lesion. Then, what are the indications? Basically, the deep-seated, which are very small lesions that can be that are very difficult to localize with the conventional open surgeries, that such as the tumor resection, stereotactic biopsy, and skull-based approaches. Some functional neurosurgeries, such as the deep brain stimulation and epileptic surgeries, and in some cases, spinal instrumentation, such as the pedicle screws, can also be done with the neuronavigation. Complications at pitfall. The main complication is that which should be considered. That is the brain shift. That is a change in the anatomy of the brain during the operation. So we should consider this because it can lead to inaccuracy or of the lesion. So registration error or brain shift can mislead targeting. Over reliance, it can also because it is a complex process. So it needs it can lead to increased anesthesia time during such as the setup of the patient and registration of the patient. This is another drawback of the neuronavigation. Then AR, MR, and VR enhancements. So in are the latest developments in the neuronavigations, that augmented realities, which adds the holographic images to the existing surgical field, that can help the surgeon to localize the lesion or help in identification of different anatomical structures and also the eloquent areas. So these are usually helpful. But VR is that it is a total generation of the visual, total generation of the visual field. It enables an immersive experience, which is by virtual VR. So this can be VR can be used for preoperative planning and for surgical training or racing. But augmented reality AR can guide the surgeon during operation because it adds additional information or holographic images to the existing surgical field. In the latest development, robotic assisted neuronavigation is also used in some centers, and with the integration of OAM, AI can also help in preoperative planning and segmentation of the preoperative images, and also intraoperative guidance. And these are also in the development. augmented reality microscopes, such as the microscopes are available which has augmented reality, such that holographic images or some other images, generated images are seen in the microscope, can be augmented in the microscope, which can help the surgeons during guidance and anatomical location of different structures. So as we have discussed, there are some limitations such as the brain shift, which is the main limitation. High cost, the learning curve is long, and setup time and registration errors can occur. This can lead to inaccuracy, and accuracy also depends on imaging quality. If there is poor imaging quality, poor preoperative MRI, then it can also lead to inaccuracy. So that concludes our session. So neuronavigation, that is the GPS of the brain, that it guides the localization of the different structures of the brain, anatomical structures, and different AR, VR, or AI assisted neuronavigations are also in development. So thank you very much for listening. That concludes our session. I'd be really happy to answer any questions.
Dr. Fran was a very good presentation, like always. The question he was asking, that in all your presentation, then the role of neuronavigation in spinal injuries was deficient. So we were hoping that you will say something about the spine as well. Okay, in spine, these transpedicular sacral fixation, the role of neuronavigation is remarkable, especially in the thoracic spine, where only a slight deviation from the pedicles can cause complete paraplegia. So it has a very, remarkable role in spine as well. So your presentation was deficient in regarding role of neuronavigation in spine. Any other question, guys?
So basically registration is the basically registration क्या है कि पेशेंट जो आपके पास पड़ा हुआ है ओटी टेबल पे, आपको कैसे पता चलेगा कि उसके अंदर वो जो हमने कहाँ से अप्रोच करना है और कैसे करना है. बेसिकली वो जो एनाटमी है पेशेंट की, वो आपने फीड करनी है न्यूरो नेविगेशन सिस्टम में, ठीक है. और फिर वो प्री ऑपरेटिव इमेजेस को उसके साथ कंपैरिजन करके दोनों को सिंक्राइज करके आपको बताएगा कि पेशेंट के ऊपर जो है वो ये एनाटॉमिकल लोकेशन है. तो बेसिकली जो रजिस्ट्रेशन का प्रोसेस है वही सबसे क्रिटिकल है न्यूरो नेविगेशन में, कि आपने वो जो एनाटॉमिकल लोकेशन है पेशेंट की वो आपने बतानी है सिस्टम को, ठीक है. और वो फिर सिस्टम आपको गाइड करेगा प्री ऑपरेटिव इमेजेस के मुताबिक.
इसमें ब्रेन शिफ्ट पे हम आते हैं. वकास, आपका जो क्वेश्चन था ना रजिस्ट्रेशन के बारे में, ये बहुत इंपॉर्टेंट है. ये बेसिकली एक सॉफ्टवेयर है, ठीक है, जो हमें लोकलाइजेशन में हेल्प कर रहा है. सिंपल रूल इसका वही है. इट इज़ अ सॉफ्टवेयर विच इज़ गाइडिंग अस टुवर्ड्स अ ट्यूमर, स्पेशली डीप सीटेड जो ट्यूमर्स होते हैं. हम चाहते हैं कि या कोई एलोकेंट एरिया पे पड़ा हुआ है, अगर कोई सुपरफिशियल मेनिंजोमा पड़ा हुआ है, पैरासिजाइटल पड़ा हुआ है, उसके लिए क्या ज़रूरत है आपको न्यूरो नेविगेशन करने की? तो आपने टेक्नोलॉजी को फॉर अ पर्पज़ यूज़ करना है, ठीक है ना. उसको आपने अपने लेयर के लिए नहीं लेना कि बस है तो हमने उसको करना है. तो डीप सीटेड ट्यूमर्स में करेंगे और ये आपको एग्जैक्ट पाथ बताएगा, शॉर्टेस्ट पाथ बताएगा, और जिसमें इंजरीज कम से कम हो. ये जो गूगल मैप होता है वो भी तो यही करता है,
वो भी यही करता है.
आपको शॉर्टेस्ट वे बताता है कि हर्डल्स कम है. तो ये इसके अलावा कुछ चीज़ का रोल नहीं है. अगेन एग्जैक्टली
उसमें यह है कि आपको एनाटॉमिकल स्ट्रक्चर्स का पता चल जाएगा कि वाइटल एलोक्वेंट एरियाज कौन से जो डैमेज नहीं करने. उसके अलावा आपको शॉर्टेस्ट पाथ वे पता चल जाएगा, ठीक है. और लीजन की लोकलाइजेशन पता चल जाएगी कि कहाँ पे है. तो आप फिर उस हिसाब से कि अगर शॉर्टेस्ट पाथ है लेकिन उसमें एलोक्वेंट एरिया अगर आ रहा है तो आप उधर से नहीं जाएंगे, ठीक है. अगर लॉन्ग भी है लेकिन वो उसके में स्ट्रक्चर जो वाइटल बेसिक स्ट्रक्चर्स हैं ब्रेन के सेव हो रहे हैं, तो वो वाला रूट ले सकते.
व्हेन यू आर एट द लीजन, फिर आपने माइक्रोस्कोप इंट्रोड्यूस करनी है, देन यू विल डू सर्जरी अकॉर्डिंगली. ओके, तो ये आपको एक न्यूरो मैंडेटरी आजकल होता जा रहा है, स्पेशली ब्रेन में डीप सीटेड लीजन्स में. आपको पता है हमारी स्पाइन ब्रेन के अंदर हम एक ही चीज़ बोलते हैं, वी नीड टू रिमेन सेफ. तो ये सेफ्टी को इंक्रीज़ करने के लिए बेसिकली ये एक सॉफ्टवेयर डेवलप किया है जिसको हम यूज़ करते हैं. जैसे इन्होंने बताया कि रजिस्ट्रेशन बहुत ही ज़्यादा इम्पोर्टेंट है, ठीक है ना. डॉक्टर रईस, आप आई होप यू आर ऑल्सो लिस्टिंग टू अस. तो रजिस्ट्रेशन में पहले तो आपने प्री ऑप इमेजेस अंदर डाल दिए ना, सॉफ्टवेयर के अंदर डाल दिए. फिर आपने पेशेंट की पोजीशन बनाई, उसका आपने हेड को रिजिड और फिक्स कर दिया. सपोज हमने टिरियोनल अप्रोच से एक पेशेंट को अप्रोच करना है, आपने उसी पोजीशन में पेशेंट की पोजीशन बना के उसको रिजिड कर दिया, और उसके लैंड मार्क्स जो हैं वो आपने कोरिलेट करने सिस्टम में डालेंगे, वो उसको सिंक्रोनाइज कर लेगा. फिर वो आपको उसका पाथवे बताएगा. जब आपने एक दफ़ा पोजीशन बता दी और आपने इधर से सरफेस लैंडमार्क्स या फिड्यूशियल्स या जो वो ट्रेस डिफरेंट मेथड्स है, उसके बाद आप पोजीशन चेंज नहीं कर सकते पेशेंट की।
Yes, sir.
अगर आपने पोजीशन चेंज की तो वो जो ब्रेन शिफ्ट आप बात कर रहे थे, फिर आपको सॉफ्टवेयर तो उस इमेजेस को फॉलो करेगा जो आपने पहले उसको दे दी है। बाद में अगर पोजीशन चेंज हुई है या खुदा न खासा CSF ड्रेन हो गया बहुत ज़्यादा, इंट्रावेंट्रिकुलर ट्यूमर आप ऑपरेट कर रहे हैं, या आपने नेक्रोटिक ट्यूमर था उसका अच्छा खासा पार्ट निकाला और ब्रेन शिफ्ट हो गया, तो वो आपको फिर वो तो प्री ऑप इमेजेस को देखेगा, पर ऑप इमेजेस को वो नहीं देख रहा ना, वो पर ऑप इमेजेस का कोई उसमें रोल है। तो ये इसका रोल सिर्फ और सिर्फ इट विल गाइड यू टुवर्ड्स योर डेस्टिनेशन, नथिंग मोर देन दिस। अगेन मैं ये कहूँगा कि जो हमारी एक सर्जिकल स्किल्स हैं वो बड़ी इंपॉर्टेंट है। अगर आपको खुद एनाटमी लैंडमार्क सारी चीज़ें पता हैं तो फिर सब होता है। जैसे हम ये फिक्सेशन कर रहे होते हैं, मल्टीपल टाइम्स एक्सरेज आपका फ्लोरोस्कोप ख़राब हो जाता है, तो ये भी एक सिस्टम है। खुदा ना खास्ता ये दरमियान में स्टॉप हो गया या कोई ब्रेन शिफ्ट की वजह से इश्यूज़ है, तो इसमें आपकी क्लिनिकल सर्जिकल स्किल्स का बड़ा रोल है। तो ये आपकी एक, मैं कहूँगा कि एक हेल्पिंग टूल है, एक सॉफ्टवेयर है जो आपको उसमें हेल्प कर रहा है। तो इसमें ब्रेन शिफ्ट और रजिस्ट्रेशन एरर्स ये सबसे ज़्यादा इसके लिमिटेशंस और पिटफॉल्स में आती हैं।
सबसे मिनिमल एरर है कौन सी आजकल टेक्निक
जो मिनिमम एरर है ना, और जो ज़्यादा प्रिसाइज है, वो रिजिड फ्रेम जो बेस्ड न्यूरोनेविगेशन है वो है। उसकी जो एरर है वो तकरीबन 4 mm से भी कम है। लेकिन जो दूसरी टेक्निक्स हैं उनमें थोड़ा सा एरर ज़्यादा, लेकिन ये फ्लेक्सिबल है। इनमें जो है वो सर्जन फिजिबिलिटी भी होती है कि वो इतना रिजिड फ्रेम जो है वो यूज़ नहीं कर रहा, और स्पेस भी जो है उसको मिल जाती है थोड़ी सी।
ये फ्यू मिलीमीटर जो आप 4 mm बोल रहे हैं, ये बहुत ज़्यादा वैल्यू है, स्पेशली जब आप ब्रेन स्टेम या एलोकेंट एरिया में है, वहाँ पे 2-3 mm भी बहुत ज़्यादा सिग्निफिकेंट हो जाता है।
यस सर,
रिजिड फ्रेम इज़ वेरी इंपॉर्टेंट जब आप ये चीज़ें कर रहे हैं।
आई थिंक वैल्यू जो है मेरे से शायद याद नहीं सही, द वैल्यू इज अराउंड 2 or 3, आई कैन नॉट रिमेंबर, बट आई कंफर्म दिस एग्जैक्ट वैल्यू।
in case of brain shift, like we are doing some surgery, what should we avoid? Like sir told us that when we're doing the ventricle surgery or tumor surgery, or we have a cistern in the pathway, so we should avoid, or we should try to avoid to open the cistern first and go to the target.
इसमें जो ब्रेन शिफ्ट है ना, प्रिवेंट करने का जो सबसे बेसिक है वो यही है कि आपने पोजीशन चेंज नहीं करनी। उसके बाद ये है कि सिस्टम तो ज़ाहिर बात है आप ओपन करेंगे CSF ड्रेन करने के लिए, ठीक है। इसके अलावा जो यूज़ कर सकते हैं वो इंट्रा ऑपरेटिव अल्ट्रासाउंड गाइडेंस, जो बाद में उसको साथ सिंक्रोनाइज करेंगे प्री ऑपरेटिव इमेजेस के साथ, वो सॉफ्टवेयर खुद ही करेगा। या फिर फंक्शनल MRI, इंट्रा ऑपरेटिव MRI ये भी यूज़ हो सकते हैं।
What is the role of, you also told that there are some more things like PTI, captography and other. But these things help in our surgery.
DTI is the diffusion tensor imaging. It mainly localizes the white matter tracts. So different pathways, such as if there is corticospinal tract from the cortex to the basal ganglia, internal capsule, and then through the brainstem, and there is a lesion in its pathway. So it can localize these pathways. And there is also functional MRI which can give a map of the functional anatomy of the brain. So when these are available, we can avoid these eloquent areas and these structures that can help in the safe resection of the lesion.
One word you use that O-arm.
So that we have seen the C-arm, which is a C-shaped fluoroscope. So O-arm is the proper round-shaped fluoroscope that can be used.
It is a fluoroscope or CT scan?
This is the CT scan. This is the CT scan.
O-arm is a CT scan.
O-arm is the CT scan intraoperative that can be used.
Yes. So there are a lot of advances actually, you know. Any other question, guys? But did you understand anything? Okay, let's conclude the session. The last question. What are the quantum dots?
Quantum dots?
Yes. Dr. Rais will tell us. देखिए, आजकल जितनी भी रिसर्च हो रही है ना ब्रेन के अंदर स्पेशली, वो किस उसके पीछे क्या थीम क्या है? सेफ्टी। ओके, वी वांट टू रिमेन सेफ। आपको पता है ब्रेन के अंदर हम सारा ट्यूमर स्पेशली ग्लायोमस निकालना तो इट्स क्वाइट इम्पॉसिबल, या फिर एलिफेंट एरियाज में। तो क्वांटम डॉट्स ये एक नैनो पार्टिकल्स होते हैं जो इंजेक्ट किए जाते हैं, और वो साइज, जितना साइज पे उनका कलर वेरी हो जाता है। अगर स्मॉल साइज होगा तो उनकी वेव लेंथ कम होगी, और वेव लेंथ कौन से कलर्स की कम है? ब्लू और ग्रीन की। अगर उनका साइज बड़ा होगा तो उनकी वेव लेंथ बड़ी शो होगी, और वो कौन से कलर्स आना शुरू हो जाएंगे? येलो और ऑरेंज। तो आपको आइडिया हो जाएगा कि कितना ट्यूमर का साइज बचा हुआ है बाय लुकिंग एट द कलर्स कैंस के अंदर।
Yes.
तो आपको पता चल जाएगा कि यार इसका साइज बड़ा है, इसका साइज कम है, तो यू कैन डायरेक्टली। और फिर उसमें क्या होगा? न्यूरो नेविगेशन का रोल होगा। वो आपको एग्जैक्टली उसी जगह पे जहाँ पे ज़्यादा साइज पड़ा हुआ है उसी जगह पे आप टारगेट करेंगे, आपको शॉर्टेस्ट वे बताएगा, और आप ट्यूमर को सेफली निकालेंगे बाय प्रोटेक्टिंग द वाइटल स्ट्रक्चर्स इन द एलोक्वेंट एरियाज ऑफ द ब्रेन। सो रिसर्च बड़ी तेज़ी से दुनिया में हो रही है। दैट्स रियली ग्रेट। थैंक यू एवरीवन।